Good afternoon. Uh, my name is Dr. Devika Gunashila. I'm the managing partner of Gunashila Hospital, and with me today is Dr. Ashwini, who is one of the senior most consultants in our hospital. She has a long association with our hospital for almost now at least 11 to 12 years. Yeah, so she's knows the ins and outs of the hospitals and is very popular with our patients. And today she and I will be talking about the importance of the tubes when we're talking about patients in the subgroup of patients who want to get pregnant. Just a small introduction about our hospital. We have been here for the last 45 years and in the infertility space for the last 35 years. And we had our first baby in 1988 through assisted reproduction technology, and that was the first baby in South India. And from then on, we have progressed by leaps and bounds, and right now are one of the oldest hospitals, private hospitals dealing with infertility in the country, and also one of the most technologically advanced hospitals in the country. Now, I would like to let you know that we are conducting this series called Ask Gunshila, and this is mainly a patient education series. It is not meant for the doctors. It is meant for patients who may be having problems conceiving, and we want to give you some information about your own body, about the science of reproductive medicine in very, very simple terms. And at any time in the program, you can text your questions to ask@gunashila.com, and we'll be happy to answer these questions. And so I would like Dr. Ashwini, to start off with telling us about what is the tube, where is it attached to the uterus, and why is it important?
Okay. So tube is a very important structure. It actually is a motile structure which is there on the either side of the uterus. Okay, and the length of the tube is about 10 to 14 centimeters.
Yeah.
And the tube is divided into various portions. The one which actually is there in the as a part of uterus is called as the interstitial portion. The one which is just outside the uterus is the isthmic portion, and which is a very narrow portion of the tube. And following which we have the caliber of the tube becomes more and more, and there is ampullary portion and the infundibular portion. But most importantly is the fimbrial portion, which has a lot of finger-like projections, and this is the portion which actually picks up the egg every time you ovulate. So what happens during ovulation is the tube actually gets attached to the ovary, and through these finger-like projections, the egg gets picked up into the tube, and tube is the site of fertilization of egg and sperm, and it also has a very important function of actually pushing the embryo towards the uterus, and it is also a nourishment center for the early embryos.
So kind of, it's going to take you through the whole process of fertilization, what exactly happens in a woman. So around the 13th or the 14th day or 15th day, depending upon your cycle, now you can see the uterus, which is a globular structure in the middle, and then you see the tube coming there, and you have another portion which is the ovary. Now from the ovary, the egg is released, and you can see that the tube is actually picking up the egg there. And when you have intercourse, your partner or husband will deposit the sperm inside the vagina. So these sperms move very, very rapidly and very quickly towards the egg. And fertilization means basically combination of the egg and the sperm. So when you have the egg, there'll be several hundreds of sperm sitting around the egg, all trying to get into the egg, and only one is successful in getting into the egg. So once this sperm gets into the egg, it has to combine with the nucleus of the egg, and that is called as fertilization. So once it is fertilized, one cell stage embryo is formed, after which it has to divide like any other cell. So 1 becomes 2, 2 becomes 4, 4 becomes 8, 16, 32, and so on and so forth. And by about the 5th or the 6th day, the embryo travels back from the end, the fimbral end, where the finger-like projections, from there right back into the uterus and into the uterine cavity, into the cavity of the womb, where it will get stuck or it will get implanted. It goes and burrows itself in the lining of the womb to form a pregnancy. So the tube is a very important structure, both in nourishment as well as in propelling the sperm from the uterus towards the egg, and propelling the embryo from the latter part of the tube right to the uterus, back into the womb. So when we actually talk about the tube, it is very important. It is a very important structure, and that is very important. It's a very important part of our evaluation of any couple seeking treatment for the inability to conceive. So can you tell us about the incidence then?
Actually, somewhere around the west, the incidence of subfertility because of tubal factor is about 25 to 35%. But in countries like India, where there are very high risks of pelvic inflammatory diseases like tuberculosis, the incidence is a little higher. And there can be blockages in the tube at different levels. So we can have proximal tubal disease, where the blockage is somewhere closer to the uterine part.
Yeah.
And we can have distal tubal obstruction, which is there at the terminal part. So most common.
Now, when you say tubal factor, I think we should kind of make it clear that there are many factors which actually contribute to a patient not getting pregnant. So one could be the husband's factor, where there is less sperm, or there is some kind of a problem in intercourse, or it could be the woman who has problems. It could start from the ovaries. So every part of the anatomy can produce a problem. Is that correct?
Yes, definitely. Yeah. And tube is also, because it is one of the very important sites of fertilization and early embryonic growth. So if there are any problems in the tubes, definitely the couple can have problems with fertility also.
Yeah.
And this proximal tubal disease accounts for about 10 to 25% of cases. And most commonly, these proximal tubal problems can be because of any uterine problems also, like if there are a small synechiae which are there at the at the area where the tube is actually starting, or there could be some small
polyps. When you say synechiae, you mean that shall we say adhesions
within the uterus.
Bands that are preventing the passage
of sperms.
Yeah.
Or there could be what is called as small polyps. They're like a little bit of outgrowths in the uterus lining of the womb, which actually blocks the tubal opening.
Yeah.
And they can have some small mucus plugs which are just going and sitting at the ostial region. Ostia is a place where it's a junction where the tube actually meets the uterus. So that is the womb.
Yeah.
So there can be some small mucus plugs over there. So these are small little problems, but they can cause tubal obstruction at the initial portion of the tube. Whereas the distal portion of the tubes, which accounts for about 75 to 90% of cases in tubal problems, they involve other problems like pelvic inflammatory diseases or infections. There are various infections. There could be parasitic infections, bacterial infections,
or it could also be tubes could also be damaged when you have had, shall we say, when a girl is young and who's had a burst appendix. Okay, so there's been a lot of pus inside, a lot of inflammation, and they've done an operation. Sometimes it becomes a huge operation. So tubes can be damaged at that also. Tubes can be damaged when you have endometriosis. So there are several reasons why a tube can be damaged, and it can be damaged at the proximal end, which is the end which is very close to the womb, or it can be damaged at the distal end. And when you say distal end, we mean the end that is close to the ovary, which is supposed to pick up the egg. So if that part of it is damaged, then we do have a problem in getting pregnant. So what exactly can result from damaged tubes? So what is the problem?
So there are a few problems. One could be the couple itself. They can have problems with conceiving. That is the most common problem that we see. There is also an increased incidence of ectopic pregnancy. Ectopic pregnancy means a pregnancy is actually supposed to be going and getting stuck in the womb. That is the womb is the actual place where the pregnancy is supposed to get implanted and it has to grow. But For some reasons, because of these disease tubes, there can be issues where the pregnancy actually doesn't get propelled from the tube back to the uterus.
Yes, so it is akin to, like, shall we say, like a garden pipe, which
Yes.
actually, which a new garden pipe is nice and clean, and so when you put water into it, it'll come out, and there's nothing stuck in it. So, but
Yes.
then in a used garden pipe, you may have mud, and you may have leaves, and you can have other stuff stuck into. I mean, stuff stuck in it. So the water will still
Conduit.
come through,
Yes.
but then the inner lining of the tube, the inner lining of the pipe will still be irregular. So
The inner lining of the tube actually has these small brush-like, epithelium, which is called as cilia. They are very important in actually the movement of the tube, movement of the embryos back into the womb, and also movement of the sperm to the egg, etc. So if there is any damage to these cilia, which you can't actually make out in any of the routine tests, so that is one of the reasons which can cause increased incidence of the pregnancy getting stuck in the tube,
yes,
and pregnancy not being able to be propelled into the uterus.
which is called as an ectopic pregnancy, and that is one of the few gynecological emergencies
Yes,
that we
definitely.
have.
And
Yeah.
also these problems in tubes can have, patients can have repeated implantation failure, in the sense like they can undergo repeated cycles of IVF, still they may not be able to conceive because of some problems within the tube. And we are going to come a little more, going to talk in detail about it in a few slides from now.
Yeah, so the thing is, now when a patient comes to us with a desire to conceive and has been trying by themselves and really has not been successful, in our hospital, we would, apart from doing a few blood tests, which is to determine the lady's fertility status, and also a semen test to determine the husband's fertility status, we would definitely want to assess the tube, because the tube is the primary structure where the egg and the sperm are going to meet. So in with us, we consider that the tube is it is a baseline investigation before you embark on any kind of treatment, like an intrauterine insemination, which we now commonly call as IUI, or even if you're going to give the patient medication, you would like to see what the tubes are like. And the tubes can actually be assessed in several ways, and today we are going to be talking about the hysterosalpingography, a sonosalpingography, and a laparoscopy. In our hospital, we do what is called as the HSG, and HSG stands for hysterosalpingography. So it is, hystero is the womb, salpings is the tube, and it is a study of the womb and the tubes together. So this is our first line of management. In a lot of hospitals, they will go straight to a laparoscopy, but we don't follow that kind of a procedure, because we feel that HSG is much less invasive. It's an easy procedure to do, and if the tubes are seen and the uterus is beautifully seen, there's no need to go any further. Your investigation of the tubes and the uterus stops at that. We don't feel the patient needs to undergo a laparoscopy where she has to have anesthesia, and she has to have all the
2-3
various
days of stay in
stay in
the
the
hospital.
And it's an overkill. Sometimes I'm not talking about all the time, sometimes, to only investigate the tubes. So we'll now talk about the hysterosalpingography. In short, it is called as the HSG. And do you want to talk about it, Ashwini? You want to tell them about?
So basically, hysterosalpingography is a radiological evaluation where we evaluate the tubes using an X-ray. So one thing what I want to tell you here is, in our hospital we do it under general anesthesia, which makes patient really comfortable, because we have had people coming and giving us feedbacks of really bad experiences when they have undergone a HSG, and that is what prevents so many of them to actually undergo this basic investigation, because the fear of pain.
Yeah, they have heard from their colleagues or friends, and saying, oh, you have any test but don't have the HSG.
Yeah. And also, so many times this HSG procedure itself is actually not done in the clinic or the hospital where they're visiting. They're usually sent to diagnostic centers where a technician performs the procedure, and
they don't really have
they're not comfortable basically,
not comfortable, and you don't have the facility for anesthetic
yes,
delivery.
and you need to have a good digital x-ray to actually visualize the uterus and tubes properly when we do the HSG, because we see a lot of films which are very poorly taken, and they're very, very hazy. The quality of x-rays are poor. So, and also because the patients have so much of pain, it can also give us a false impression that the tubes are blocked, because what happens when the patient has so much of pain during the procedure?
It actually, the tube's going to spasm, and when you have pain, the internal organs is going to spasm. So when you have spasm, the tubes which are starting at the womb, they will just shut, and so they will not allow that radio opaque dye that we actually put in to go into the tubes, and so you get a false impression that the tubes are blocked.
Tubes are blocked, and then the next way you can actually go forward is either do an IVF or go for a laparoscopy. So I don't think we should give a good anesthesia before we actually proceed with this tubal patency test.
So what you can actually see over here is how is the HSG done. A patient is actually got into position, and what we do is we insert a small tube-like structure into the neck of the womb from the vagina, and then we push a radio opaque dye which will fill up. You can see the inverted triangle, and that is what the uterus is, and on either sides you can see the fallopian tube has been marked as the fallopian tube. They're thin thread-like structures which then where the dye passes through, and then you can see it has come outside the fallopian tubes, and so that we will say is a patent tube, because the dye has actually traversed the uterus and traversed the tubes and has come outside. So this is another picture of
this is a normal HSG.
Normal HSG. Again, you can see the uterus. There are various sizes and shapes of uterus. They're all normal. It is you can see the uterus now, the womb that is bent to the left side, the R is the right side, and that's how we label our x-rays. So you can see that the uterus is bent to the left side, but still you can see the tubes and a beautiful spill of dye over there.
So the small hairline structures are the tubes, which are slowly increasing in its caliber, and there is a spill of dye. And one more added advantage with HSG is you can also have an evaluation of the uterine cavity.
So to a large extent,
to a large extent. This is a normal X-ray, but whereas we can also pick up a few signs with abnormal HSGs also. But HSG is an indirect method of evaluation, but it can give us at an outset an idea about the tubes by and large in detail. So this second category is where there are some mild to moderate problems in the tubes. There could be small elevations in pressure when we are trying to actually push the dye, and sometimes
or the tubes can actually be stuck in certain areas, like inside it could be stuck to the pelvic wall, or it could be stuck to the intestine or something like that.
So actually the relationship between the egg, the ovary and the tube is little bit altered in this set of patients. However, they can actually have normal conceptions, but these set of patients who have mild to moderate tubal problems, they actually have increased risk of ectopic pregnancies. And they do have problems with fertility also.
So now this is a third category where you actually have blocked tubes or severe tubal disease. The one on the left of the screen is completely blocked tubes. You can hardly see the tubes. You can only see the outline of the beautiful uterus, but you can't see the tubes at all. And so you would call this as a proximal blockage. That means a block that is happening just at where the tube enters or leaves the uterus, so the junction of the tube and the uterus. And the one on the right, you can see there are rigid tubes. The tube, you can only see a portion of the tubes, and this quite often, I mean, I'm not saying all the time, but in our country quite often happens in the situation of tuberculosis. And I think we have had, Ashwini, patients where we have had they have actually come to us with this kind of a picture, and then we say, okay, now we have to do a laparoscopy, because that is the next method of investigation, especially if they've had it outside, and you ask them, have you had severe pain during the procedure, and they say yes, then it may be also spasm. Yeah, that's what we talked about a little earlier.
Correct.
Where the tube has actually it's gone into spasm and
into
closed.
spasm. And so the first picture, what we are seeing towards the left, it could be because of tubal spasm also.
Yes.
But here on HSG, when we see, we feel that it could be a severe tubal disease.
Yeah. But then the thing is that now so if now to evaluate whether it is actually a spasm and she actually has normal tubes, or she has severe tubal disease, the next step would be a laparoscopy. Isn't that correct?
Yes.
And the advantages of a laparoscopy would be
laparoscopy basically involves direct visualization of the uterus and tubes. Basically, what we do, we make small cuts on the abdomen, somewhere near the navel, and maybe another 1 or 2 more cuts. They're all about a centimeter or 2 centimeter long, and we put in what is called as a telescope. So we have a direct visualization of uterus and tubes with laparoscopy.
Yeah, the advantage of a laparoscopy is you're not only, I mean, nowadays we're using only 0.5 centimeters or half a centimeter cuts. So you'll only have about 2 cuts, one in the umbilicus and one somewhere else in the abdomen. But apart from that, we'll go into that part later on. But the advantage of a laparoscopy is that you can actually see the tubes, you can see the uterus, you can maybe do a little bit of a therapy.
Yes.
You can again push the dye from down below. You can see whether the dye is flowing out or not. Sometimes it just stops halfway, it doesn't come any further. Sometimes you can actually, we have had, don't you think that we have had so many women who have come with these kind of blocked tubes, and then we found tuberculosis?
Yes, definitely. And they don't have any clues other than maybe on HSG like this. They're completely normal. They have normal menstrual cycles. Their only problem is they have not conceived.
Yeah.
Otherwise, generally no abdominal pain or no loss of weight, no loss of appetite, quite healthy looking.
So they're not the typical tuberculosis patients who are coughing their lungs out and then producing sputum and blood in the sputum and things like that. They are just like you said, just very
they are just very much normal, and their only problem is that they have not conceived. But several number of times we have actually picked up these infections in the tubes because of laparoscopy.
And I think that is also the way that genital tuberculosis presents a lot of the times. I mean, there are other symptoms of genital tuberculosis as well, but this is one of the main main ways that they're present. So this is another X-ray where you have now the distal end. So that means the end, which is actually close to the ovary and which is supposed to do its job by picking up the released egg and transporting it towards the sperm, that is blocked. Is that correct?
Yes. This is a distal block. So what we can see here is, you can see the tube in entirety, but the terminal portion of the tube, which is there closer to the ovary, is actually ballooned out. And this is what we call it as a hydrosalpinx. So
where hydro means water and salpinx means the tube. So there's basically a collection of water in the tube. And it is not really water, it is basically a lot of secretions and things like that.
Some toxic fluid, etc. And you don't see any spillage of dye in the pelvis in this particular X-ray. So the tube is actually blocked at the distal end.
Yeah, and this is really not conducive. Even now here, if you have these kind of badly damaged tubes, whatever the reason it may be, then that we will only find out once we go in and do a laparoscopy and things like that. These are not conducive to a pregnancy.
Definitely not.
And also, even if you do an IVF, because the tubes are blocked, because if the tubes are blocked, the next situation would be an IVF. If you have a confirmed situation where you have confirmed that the blockage of tubes is present, then you will go in for an IVF. But even with an IVF, you cannot do an IVF with these kind of tubes.
These kind of tubes, they are definitely. There are so many patients who come and who are like, anyway, I have a tubal block, just go forward and do an IVF for us. But with patients who have these kind of blocked tubes, along with this kind of swollen tubes, where there is what we call it as a hydrosalpinx, all these secretions which are there in the tube, they're all toxic, both for the embryo as well as for the uterus. So it actually alters the way uterus receives the embryo, And this because it is actually communicating into the uterus,
Yes.
the toxic fluid can actually enter the uterus. So even when you do an embryo transfer post IVF, it can actually damage the embryo. It can be so toxic to the embryo, or it can just wash it off.
Correct. So it either washes it off or it is toxic, so the embryo dies. So there is no point in keeping these kind of tubes,
Yes,
isn't it?
yes.
So our
And
IVF also is going to fail. But then when we say toxic, it is only toxic to the embryo. It is not toxic to the patient. You know, you
definitely
can
not.
still have hydrosalpinx and you can be sitting there and you're fine. Nothing is going to happen. The only thing is they may complain of a little bit of an excessive discharge.
Excessive discharge
Yeah.
or some kind of a mild abdominal pain, but
Yeah.
it doesn't cause much of trouble for them. And with these kind of tubes, even after doing an IVF, the embryo can go and get stuck in the tube.
Yes,
Yes,
exactly.
and
That's another story. Yeah.
even with an IVF, when we go and put in the embryo inside the uterus, because of the diseased tube, the embryo is free to move once it is inside the
Yes,
uterus,
yes.
and it can go and get stuck there, and it can cause ectopic pregnancies.
Correct.
So these tubes actually are of no use.
Yeah, so they have to
So
kind
they
of
have to be
be
removed.
removed. Yeah. Yeah, so this is a tubal cannulation and a selective salpingography. So what we see now, these are kind of, now here you actually see, if you look closely, you can actually see a small tube, you know, which is an opaque kind of a structure, which is going towards the left, isn't it?
Yes, yes.
Yeah, which is going to the left, and you can see that it is kind of gone towards where the uterus meets the tube, and then dye has been pushed and the dye has outlined the left tube, and it has also come out into the pelvis. Now sometimes when we do have tubes that are not that are looking blocked, then the patient really does not want to have a laparoscopy, and we're also not too keen on her having a laparoscopy, maybe because she's only been married a year or 2 years, and then you know they have been trying, and you really don't see too much wrong, anything wrong happening with the patient's history, which should lead you to suspect other causes. Then we would like to do a salpingography, and this is called as a
Tubal cannulation, transcervical tubal cannulation.
transcervical
So
tubal
basically,
cannulation.
it involves passage of a small tube from within the uterus, and trying to open up that small blockages, whatever are there at the initial tubal opening. So at the junction where the uterus meets the tube.
Yeah.
So these are done in a very select group of patients where they have not been married for a long time, and they have given history that they were not really comfortable with the HSG, and in their own mind they feel that they don't want to go for an invasive procedure like a laparoscopy so soon. They come asking for opinions. Is there anything else that we can do other
Yeah.
than a
And we
laparoscopy?
would want to do this.
We would advocate this for a few subset of patients.
Yeah.
So
And is
this is a sonosalpingography. Actually, it's a old method, not followed too much these days. It's just an ultrasound examination of passage of fluid within the uterus and outside the tube. It is not actually so much reproducible. The picture over here is very beautiful because the tube is actually enlarged nicely, and you can see the entire the saline which is filling up the tube, but we don't get such kind of clear pictures during the sonosalpingography, and there is always a lot of observer to observer variations.
Also confusion as to, you know, I mean, if you're not so observant, you can actually miss which tube is
Actually blocked,
and which is
and
which is
we can't
patent.
reproduce. I mean, like, you can take this X-ray, go for multiple opinions.
Yeah,
You can't
exactly.
take this
Yeah,
because
it is
it's
observer related.
observer related,
Yeah.
and you they just push little bit of saline from down below, and they take they take an ultrasound examination to see if there is passage of that saline into the peritoneal cavity, but it is not advocated now.
So here is the laparoscopy. That's what we talked about. You know, it is basically putting in, using about half a centimeter cuts in the umbilicus, and then another one on the side, a little bit lower down, and having a look at the uterus. And then this we would do if we had we just talked about it. We've had bad tubes, or the uterus, the X-ray is not very good, and the patient has been married for a longer time, and we don't want to waste time. She's
And
had
they have
multiple treatments,
taken multiple
yeah,
treatments.
which has not been okay, which not succeeded, and or we find diseased tubes, which is typical of tuberculosis, or we find enlarged tubes and things like that. So this is another, like I said, in our hospital we use it as the maybe the second or the third
Second line
line
and third line.
of management and diagnosis. We would first anyway stick to the least invasive, which is a HHA, and we're very comfortable with it. We've been doing it for a long time. And you would like to tell them about this?
So actually, laparoscopy is considered as the gold standard for for evaluation of tubes. The added advantage with laparoscopy is that it's not only to evaluate the tubes, you can also correct some minor abnormalities which are there, and they can be you can diagnose so
other
many
conditions,
problems.
yeah.
And we have had couples who with the initial evaluation everything seems to be normal. The husband seems to be normal, the wife seems to be ovulating. The HSG has shown some problems, but and they have taken so many treatments, and nothing seems to be really wrong. But when we go inside and put in a scope, we see whole lot of problems. There could be endometriosis, there could be severe infections inside. Those things cannot be diagnosed just by the basis of scans or simple x-rays. So
Now over there you actually are seeing the dye coming out of the tube, right?
so
You
the blue dye, which is basically what we do, is we put in little bit of a blue dye from down below. You can see the tube in entirety, as well as the ovaries.
Yeah.
And the blue dye is seen coming out of the other end of the tube.
Yeah, so you can actually, in the first picture, you actually see the uterus, and then you see both the white structures of the ovaries, and the tubes are on the either side. And then this is a close up of the dye coming out of the tube, which is a normal tube. So that seems to be fine. And again, over here, this is a slightly more complicated picture where you actually have the ovaries sitting on one side, and then you have a larger tube which is swollen, and that is called as the hydrosalpinx, which is not conducive to a pregnancy, and we would definitely want to take that out if we see that. And that can also happen when you have endometriosis. Endometriosis is quite often diagnosed on a scan, and then when you go in and you have to kind of open it up, you have a huge mess inside the abdomen. Ovaries are stuck somewhere, the tube is stuck somewhere else, and the architectural orientation is completely lost.
So these are other problems. There can be, the tubes can be stuck, and the tubes need not have to be directly involved, but there can be lot of additions. The additions are like, attachment of all abnormal different structures to one another. And advantage of laparoscopy is when you go in and see, you can actually diagnose is one thing, and at the same time you can take corrective measures. So
Correct,
here in this laparoscopy, what they're doing is they're trying to break open all those additions, and they're trying to deagglutinate the tube, in the sense like they're trying to
open it up
open up the tube and trying to make it patent. So whatever attachments are there, abnormal attachments are there around the tube, they're trying to normalize it as much as possible. So this can help in natural conception sometimes.
Yeah, and also over here you have some peritubal adhesions.
There are those endometriotic spots.
Yeah.
So they're basically endometriosis is basically the presence of the tissue which is lining the womb is called as endometrium, and which should be limited to the lining of the womb only. But there are people who have this kind of a tissue which is present outside the womb. So it can be in any of the abdominal areas, or it can be on the ovaries.
And so the tubes can go and get attached to
and there can be
deposits.
some altered relationship between the ovary and the tube. So the tube is supposed to actually encircle the ovary like this. So because of this attachments, the tube will face somewhere, ovary will face somewhere. So this can cause problems with infertility.
Because if you don't have a correct alignment of the egg of the ovary and the tube, whatever the ovary is releasing is not going to be picked up by the tube. That's the basic concept. So here we would do a hysteroscopic annulation. Now, what is a hysteroscopy? We will come to it in our next few series. But a hysteroscopy is basically an imaging of the inside of the womb with a special camera called as a hysteroscope. Now, that is a telescope. Now we sometimes, if we do have, now we push the dye. A patient has come to us in the X-ray. She shows blocked tubes, so we want to go and find out and see if there's anything there. We push the dye, and then the dye is still not coming out. Then what we would do is we would use the hysteroscope and under vision actually direct a thin small plastic tube, which is called as a cannula, towards the junction of the tube and the womb to see if we can, unblock a few small blockages that may be there, and push the dye again and see. So this is an extension of what we would do in testing the tubes through.
This tubal cannulation can be performed only in places where there is proximal tubal blocks. So
Yes,
the distal
yes.
tubal
This is,
blocks
yeah.
we can't.
Yeah, like
perform
there's no
this.
point doing it for a hydrosulfix because the tube is anyway patent, isn't it?
Yes.
Yeah. So,
Do all patients who have blocked tubes need IVF? So that is a question now. So not necessarily. So if there is unilateral patency, that means one tube is completely blocked whereas the other tube is completely normal, you can still have natural pregnancies. So you can try smaller treatments like, ovulation induction, and you can have a timed intercourse, or you can have what is called as an intrauterine insemination. So these are near natural methods of conception. So we'll come in detail.
I just want to say one thing. Just because you have one tube that is not okay does not mean you cannot conceive. So we have had so many patients who have had ectopic pregnancies, and that one tube has been taken away, and they still manage to have normal pregnancies and deliver normally, and then go through the whole thing really nicely. The second thing is HSG is just a initial investigation to give us some idea about the tubes, and just because we don't see the tubes all that very well like what we think we should see them,
we don't have to jump and do a IVF.
Yeah, you don't have to jump into an IVF. You don't have to jump into an uterine insemination. You can still reassure the patients and say, look, you give it a trial, especially if they've been mad for a very small amount of time and not really tried that very well. Just we can always give them the benefit of doubt.
So many times we have seen patients conceiving just because they have had an HSG.
Yeah, that's another thing where HSG has been one of the treatments.
Your treatments for
actually,
because there are some small mucus plugs somewhere, it would have been stuck somewhere in the middle of the tube, and because you have just flushed the tubes with the dye, and it all just opens up.
Yes, and that reminds me of one of the my Dr. Sulochana Gunshila, who actually when she came back from England, she was working in Vani Vilas, and the only thing that they had, the only armamentarium that they had was a HSG. So she did this, because she was passionate about, this was, I'm talking about 1965, and she was very passionate about infertility and trying to get women pregnant. So apparently she used to collect, she used to ask people to donate, including herself, and then they would buy the films and buy the X-rays, and and then go ahead and do the HSGs, and
people
get pregnant.
So all you may require is just an HSG.
Yes.
And we see many patients having undergone so many treatments without even having the basic evaluation of tube. That really saddens me.
Yes.
So many times.
That's so I think if you are under treatment, you must actually make sure that your tubes are tested, because these are very important structures. And coming to bilateral tubal block, if you have a bilateral tubal block, you will still want to confirm that it is a bilateral tubal block through laparoscopy. You won't take your X-ray finding as final. And if you do have a bilateral tubal block, then your next step is only
IVF or intracytoplasmic sperm injection, because there is no way egg can meet the tube in case of bilateral tubal block. So the egg and sperm have to be made to meet outside.
Yeah.
In the lab.
Yeah. But that's also one more thing about, just a small note about ectopics. See, ectopics happen when the tubes are damaged. In our country, tuberculosis is one of the very important reasons for one of the very important, not the only reason for tubal damage. But then once you've had an ectopic, the chances of having another ectopic increases to a
Increases.
large
Yeah.
extent. So that is something that one should look at and keep in mind. And I do think that we have come to the end of our program on the on the role that the fallopian tube plays in fertility. And this is, I think, the end of our second episode in this series of
Yes.
Ask Sheila for our patients. To we would welcome any questions either at this stage or any other stage. We will put up the Ask Sheila website, and you can send your questions there if you don't want to type it in here. And our next episode will be learning a little bit more about male infertility on next Saturday. I'm not sure whether the date is correct, but it will be next Saturday at 1 p.m. and that will be done by again our senior consultants, Dr. Jyoti and Dr. Rajeshwari. And we'd like to thank you all for having joined us today, and looking forward to you joining us in our next episodes. So thank you so much,
Thank you.
Ashwini. Thank
Thank you,
you.
everybody.
Thank you.